picture, you can appreciate hemoglobin is 4.7 and blood test count is 40,000 and WBC count is low, EC is 1500. Other things we can see currently liver function is normal and pH is high is about 700. So now the question is when there is cytopenia, what comes in our mind? First thing comes in aplastic anemia, and this age maybe there is MDS, PNH, and myeloproliferative neoplasm. So which of the following would be the most useful in achieving diagnosis in this patient? So three things we will do. First we will correct fluid, some hemolytic workup, and the bone marrow. Let's see what can. You can see in imaging we couldn't find anything except capitulosplenomegaly. Film shows fine, platelets are adequate, myeloleukemia is there. Immunological and factive screening is negative, nutrients are normal, and component levels are normal, and interestingly, bone marrow is completely normal. Now, which of the following would be the most useful achieving diagnosis in this patient? The rest is left CT scan to see if anything is hidden. They found that there is hepatosplenomegaly. There is some lytic lesion as well in the bone. So plasma cell maybe, and left breast mass also shows two small nodes as well. So breast cancer as well. Let's see. So which of the following will be the most useful achieving diagnosis in this patient right now? So two things are there. We should do mammogram. We should do myeloma workup. So mammogram was done that revealed multiple bilateral hypodense mass, that is category 0. Then they found ultrasound, they found bilateral hyperdense mass like lesion. But what we should this mass? No mean, no treat. Do biopsy. Biopsy was done and that revealed you can say fibroadenoma. And meanwhile, myeloma workup found there is no in protein and 24-hour urine collection was also normal. So what to do? We are at same place. Which of the following then most useful? Then again I appreciate Dr. Arif Aral says, skip bone marrow if there is chances, repeat the bone marrow. So what was done? Repeat bone marrow was done. The bone marrow was compatible with the diffuse large B-cell lymphoma, very high Ki-67 is 80%. It was BCL2 is also positive, CD20 positive. So now we have now based on the goal of NHS first is make us ABC. A means accurate diagnosis. Now we have accurate diagnosis, diffuse large B-cell lymphoma. B is before beginning treatment, review the labs again. Let's review. So if we review the labs, then we found the patient has fever, splenomegaly, and cytopenia, and ferritin was 3000. What is missing here? Is it shower of cytokines? Yes, it's shower of cytokines. Patient has fever, splenomegaly, cytopenia. Patient has high triglyceride, patient has low fibrinogen, and very high ferritin. So what is this? Patient has HLH. HLH secondary to malignancy means patient has DLBL with HLH. Now we know cytokine cause fever, pancytopenia. So this is the typical found in this patient. So where we stand? The patient has actually stage 4BS for spleen, stage 4BS unfavorable. Now we have this patient, so what we to do? Next step is the treatment. So if you go by NCCN guideline, the front line in diffuse large B-cell lymphoma, the first line treatment is R-CHOP chemotherapy. And you can give dose adjusted or hook in some cases, which have aggressive disease. And you can consider also IT or thyroid based on the high steps in this involvement. So what we should do? We should have HLH. Check the HLH guideline. There is, we have to do HLH 04 guideline as well. So treatment includes targeting the underlying disorder, which is DLBL, and also continue to control the immune dysregulation. The key pillar in HLH is what? You can see here, dexamethasone etoposide. So now, this is HLH 2004 protocol. So we have to treat DLBL with HLH. Now, what is your thought? Pin code is 50-year period. Diagnosis, high grade, stage 4 BS, diffuse large B-cell lymphoma, with HLH, with high IPI score. So what you will do? You have choice, standard R-CHOP 31, R-CHOP 40, though there is still article, or if you are, this was case in 2019, suppose in 2022, what you will do? You will go for the archer, or you will treat first HLH to protocol or clinical trial. So these things are actually reasonable. So what we should do to kill two birds with one gun, that is possible? Yes, this is possible. If you use those existing RPO protocol, you will use also etoposide dexamethasone as well. So why not we use this one? So we started this patient, and she tolerated first cycle and second cycle also in January 29. She has very good improvement. And unfortunately, 17 January 29, she ended with us, vomiting, fatigue, neutropenia, and she has subbed and related to a massive hemorrhage, and she underwent ventilator, and she was intubated, she was in ICU. Now the patient is in ICU, aggressive diffuse large B-cell lymphoma, HLH is there. What we should do? We should sit tightly, not do anything. I don't think so. This is a good idea. Then what we do? The good thing is we have to still. We cannot go to the still RPO this time, and we cannot switch other chemotherapy. Best thing is we can start this protocol with the subsequent treatment, which is safe during patient of bed. So we did this one. She completed induction chemotherapy while patient was in ICU, and now the thing is what we should do. Two cycle chemotherapy, then induction for HLH protocol, then what we should do. Now we restart, though the state RPO, and followed by HLH protocol maintenance. This is how we take this patient. So now you can say this is the whole journey of the patient. Patient came with severe pancytopenia, we started with RPO, then patient went because of chemotherapy side effect, then patient had maintenance phase HLH protocol, and then the patient has given again dosage RPO chemotherapy. Now the patient is in the CR. So after 1 year, patient landed again the complaint of abdominal pain, and we found now the lymph nodes over there in the abdomen. Biopsy was done, that was coupled with the diffuse large B-cell lymphoma. There is no parameter of HLH. Now what we should do? I know the standard, you know also the standard salvage chemotherapy, which we should go for autologous transplant. The chemotherapy was given RDAP, and after 2 cycles, the patient was CR. She completed 4 cycles, but we don't access our autologous transplant at that time as well. And the patient was just given chemotherapy, and she is poorly, she couldn't go for autologous transplant. So over the 1 year, she became dead. Now this is the whole journey. The patient had initially diffuse large B-cell lymphoma with both the involvement with HLH. So this is the first diagnosis. We started to adjusted RPO 2 cycles. Patient went ventilator. During ventilator, we started induction phase to HLH 94 protocol. Once patient is stable, we restarted again to adjusted RPO for more cycles, 6 cycles, and then she continued maintenance phase of HLH protocol. She was good for 1 year, then again she came back, the patient again received RPO protocol. So this is our journey, you can say, and think over this, and we will discuss some questionnaires in this patient. So what we see the roles of oncology are reminded here. A, B, C. A means accurate diagnosis. Think widely, not miss the diagnosis. You have noticed we have done 2 times more until we found the diagnosis, very difficult. And before beginning treatment in the labs, and we found HLH was behind the diffuse large B-cell lymphoma, and C is considered a potentially curable option with least long-term toxicity. We kill 2 birds with 1 stone, which we did here. And rule number 1. Rule number 3 is never forget rule number 1, which is what? No meat, no treat. You have seen we have done 4 times biopsy, 2 biopsy from the bone marrow, 2 biopsy from tissue, breast, and lymph node, and finally we reach a diagnosis. So this is again similar, just one slide. One elderly lady, poor performance, multiple comorbidity, aggressive diffuse large B-cell lymphoma, invading the pancreas, stomach, small intestine, adrenal gland. She has very high chances of 50% CNS involvement. So now this is more the same like as I mentioned, aggressive large lymphoma, what we should do. Again, in this patient, we just give Minitor with IG chemotherapy, and after 6 cycles, she's in complete remission. So now over 3 years, we can follow to us. So this is the first CD in complete remission. So the idea is to show you, about the NCC, and you can say how we define, aggressive or double HLA. Anything you there with the mic BCL2 and BCL6, if 2 is there, we call it double, and 3 triple, and they are very poor prognostic, high LDH, bone marrow, CNS involvement, high IPI score. And here you can see the guideline. If the patient R-CHOP is suboptimal, mini R-CHOP may be considered for frail patient like we did in our patient. And though the state, EPOC should be given in aggressive young patient. So we give R-CHOP with patients. So now my questions is during this both cases. What is the optimal therapy for double lymphoma? 2022, should it still be dose-adjusted or chemotherapy or polar-based chemotherapy? And what about the CNS prophylaxis? Should be given double and triple? It should be given RT or high-dose methotrexate. If high-dose methotrexate, it should be given between the cycle of end of therapy. If high-dose methotrexate is given at the end of induction, then how many cycles? So these are the questions we will discuss with the experts during discussion, and especially, as I mentioned, diagnosing field I will Thank you very much. Good evening, ladies and gentlemen. Thank you for